Good morning, everyone, and welcome to today's webinar. We are glad you are here. Today, we are talking about a practical guide to renal and bladder ultrasound. My name is Jennifer Price, and I am SMA's Communications Director, and it is my pleasure to welcome you today. We have just a few housekeeping items that I will run through before I turn this over. Cameras are disabled, and your microphones are currently muted. We will answer all questions at the end of today's session. And if you would like to ask a question during the webinar, please type it into the Q&A box and it will be answered at the end of the presentation. If you would like to ask your question at the end using your microphone, just simply raise your hand and you can ask your question at the end. At this time, I would like to turn over the webinar to our faculty, Dr. Tatiana Havrluk.
Hi, everyone, and welcome. I'm happy to be here speaking to you about renal and bladder ultrasound. And before we get started, Haley, would you mind sharing some polls with our audience so we can learn a little bit more about who's in the audience?
Yes, I'm going to launch poll question now, the first one.
All right, so most of you are interested in improving diagnostic accuracy and confidence. There are a few interested in decreasing referrals to the ER, and of course, staying on the cutting edge of medicine. Tell us in the chat. Did someone put something in the chat? Let's see. They have not shared yet. Well, feel free to share. Oh, okay. Marilyn says, I can't see. Hi, Marilyn. I can't see the question, but I share the same ideas.
It might be because she might have came in a little bit. You ready to launch question 2?
Yes, let's go. Okay, we've got some mostly primary care providers, some emergency medicine and urgent care, and mostly providers and an administrator as well.
You ready for question 3?
Yes. All right, we've got quite a mix over here. We have some people actually performing POCUS and have the workflow to actually bill for it. Some are performing and not billing for it, and some are not using it clinically. All right, well, thank you so much, everyone who participated in the poll, and I'm going to get started with my presentation on renal ultrasounds. All right, so I want to start off with some of the indications that you can be using the renal and bladder ultrasound for in the patients you are seeing. Those are the patients with flank pain and maybe lower abdominal pain, patients who are presenting with hematuria or inability to urinate or difficulty urinating, or maybe patients with acute kidney injury where you are trying to rule out some of the causes that might be causing the AKI. And of course, definitely remember the common mimics of renal presentations that are really important to pick up. Those would be aortic pathology. So the AAA or aortic dissection, those patients will need more than a renal and bladder ultrasound. And the focus questions we are answering with renal ultrasound are, is there hydronephrosis and is the bladder distended? Those are the main 2 questions. You can do, of course, more with point of care ultrasounds. For example, you can assess Foley placements, and we can cover a little bit of that at the end of this session. And why should you be doing renal bladder ultrasound? Well, a lot of you have answered that you want to improve your diagnostic accuracy and confidence, right? So you get immediate answers at the bedside to really decide on your next step for this patient. So that's a huge benefit. There's quite a bit of literature on renal and bladder ultrasound as well. And POCUS does have 84% sensitivity for hydronephrosis in renal colic patients. That sensitivity increases to 94% when moderate to severe hydronephrosis is present. There was also a landmark study that was conducted in the emergency department in 2014, when it was published in 2014, but it looked at the ultrasound first approach for patients presenting with possible renal colic. And what they found was remarkable. So with POCUS first approach, they were able to avoid a CAT scan in 76% of the patients. And that translated in more efficiency, no radiation for those patients, and also huge cost savings, both for the healthcare system and for the patients. So there's plenty of reasons why it's a good idea to have that in your clinical repertoire. And let's go over the renal anatomy just a bit here. So starting from outside and moving inward, we have the renal cortex, and that typically appears hyperechoic on the ultrasound. Then we've got the renal parenchyma, and that's divided. Um, Sorry, I meant renal capsule, not cortex. So there's renal capsule, and then the renal parenchyma is divided in the renal cortex, which is more towards the outside, and the renal medulla on the inside. Inside the renal medulla, you will also see pyramids, and those typically are quite hypoechoic on ultrasound. And then finally, in the center of the kidney is where the collecting system is, and that's where the renal pelvis and the calyces reside. And when the kidney is normal and there's no obstruction or distension, those calyces and the collecting system and the pelvis will be all collapsed and look hyperechoic or bright white on the screen. So the center of the kidney should be hyperechoic in a normal kidney. So let's a little bit more about the anatomy. Well, kidneys are retroperitoneal. They're quite low on our bodies. So anywhere from T12 to L4, you can be scanning them typically in the coronal or sagittal view, and then getting also a transverse view. The right kidney is a bit lower than the left, mostly because the liver is pushing it down. Right kidney is also more posterior and inferior to the liver, while left kidney is inferior and medial to the spleen. For those of you who like to think about that. And then in terms of the normal size of the kidney, although typically I do not measure the kidney when I'm doing POCUS unless it looks very large or very small, but these are the normal numbers, right? So they are typically 9 to 12 centimeters long, 2 to 5 centimeters wide, and 3 to 4 centimeters in thickness. You want to be using your curvilinear probe, or if you have an all-purpose probe, that's what you'd use on a renal or abdominal or retroperitoneal setting. The point of this is that this is a low-frequency, high-penetration probe. So you want to be able to visualize the whole kidney. And in terms of technique, I mentioned it already. Typically, we get a coronal view of the kidney, and that involves scanning in that posterior axillary plane with a probe marker towards the head, and then also a transverse view where you rotate the probe 90 degrees to get a good view of the kidney in a short view. You could also have the patient rotate on the side and get more of a sagittal view of the kidney from the back. So if you wanted to get more views, if you are having trouble getting that coronal view, you could do that on the patient. And for the bladder views, we are getting also two views, one transverse view with a probe marker towards patient's right, and this is the standard in ultrasound, and a sagittal view with a probe marker towards patient's head. And really the big trick with this bladder view is, and the bladder is small and not full, basically. It doesn't have a lot of urine. It's actually quite inferior. So you really want to be aiming the lens of the probe. Think of it as a flashlight. So you're shining the light really towards the rectum, towards the feet of the patient to get that bladder image. So sometimes it's challenging when the bladder is deflated. And before we move on, I also wanted to mention, in terms of getting those renal views and positioning, on the left side, that could be a challenging view because the ribs are in the way on that side. So you do want to rotate your probe clockwise in an oblique orientation to get in between the ribs if you need to. These are the images you should be obtaining of the normal kidneys here. So this is the right kidney in the coronal plane with the liver and the superior portion of the kidney here. So this is towards the head. This is towards the feet. This is closest to the probe. This is furthest for the probe. And this is our transverse of the kidney here. And notice that the center of the kidney is hyperechoic, meaning the collecting system, your pelvis and your callus, these are all collapsed and not distended with urine, which would appear anechoic. On the left side, it's literally pretty much the same thing, other than instead of the liver, you're seeing the spleen on that coronal plane. And these are the bladder views. This is the transverse view of the bladder on the left, and this is the sagittal view of the bladder on the right of the screen to measure bladder volume. Some of the probes now have auto calculation features, so if you have access to that, you can use it. Otherwise, you can do it manually, and that involves getting measurements of the actual bladder width, bladder depth, and the bladder height, and multiplying all of them together, and then also by a coefficient. I typically use 0.6, although depending on the bladder shape, the coefficient can also be 0.52 or 0.7. Just remember, if you are using 0.7, it might overestimate the amount of uh, uh, volume of urine there is in the bladder. So I stick with 0.6. So what would hydronephrosis look like on ultrasound? And before we do that, I actually wanted to show you how we can use POCUS in your clinical decision making for a patient with possible renal colic and also the patient with bladder distension. Um, so say you have a patient who is presenting with flank pain or hematuria or difficulty urinating, and you are either concerned for renal colic or maybe you are looking for urinary retention. If you are looking for urinary retention, you would obtain a post-void bladder ultrasound. If you're concerned about renal colic, you first want to screen for any kind of high risk features, right? So patients who are older, if they're having a fever, if the pain is really not controlled, if they're having a lot of vomiting and not tolerating fluids, if they're really not urinating at all, if there is concern for aortic pathology, if the UA shows infection, those are pretty high risk patients, right? So those patients' differential would be aortic dissection. It could be a very large stone that's causing such an obstruction that they are not urinating. It could be an infected stone, which is a urological emergency. So those cohort of patients, you actually probably want to escalate and send them to emergency department, get a CAT scan, make sure you're sending that urine culture if the UA showed an infection. However, you have a huge cohort of patients that you can still be doing ultrasound for to make a clinical decision. So in all of those patients who are presenting with possible renal colic and they don't have the right high-risk features, you want to get a focused renal and bladder ultrasound. And depending on your results, this is how you could manage these patients when you're seeing them in your clinic. So, say you have a patient and you are finding mild hydronephrosis or maybe moderate hydronephrosis, and there's no urinary retention. So, this patient, depending also on their presentation, likely has a stone. If you're suspicion for stone was high to begin with. So in these patients, you could consider a CAT scan and urgent GU follow-up, especially for moderate hydronephrosis. However, there's plenty of literature saying if it's mild hydronephrosis and they don't have high-risk features, you are good to sticking with POCUS. And these patients do not necessarily require CAT scan, even if it's their first presentation. So this is a really great way of using ultrasound to save patients CAT scans, trips to the ER, save them radiation and costs. Say you found a severe hydronephrosis, and I'll show you all of those in the upcoming slides, and maybe they do have urinary retention, maybe not. Well, severe hydronephrosis, the kidney is at risk, right? Their parenchyma is affected. You need to send them to the ER for further workup and possible decompression. Say you found nothing, there's no hydronephrosis, no urinary retention. Well, there could be a couple of things in a patient who is presenting with flank pain concerning for a kidney stone. This could be that they just passed the stone, and that's why you're not seeing the obstruction. This could be that they are also really dehydrated, and there's just not enough urine that's being backed up to show the hydronephrosis. So you can do a couple of things with that patient. One could be you could hydrate them in your office, either through IV or have them drink a bunch of fluid, and then you can re-image them. Or you can assume that this was a past stone and just give them a close follow-up. Or if the stone wasn't high on your differential, you might need to look for other things that could be causing their pain. And a lot of times, in my experience, musculoskeletal pain can mimic that renal colic presentation. So that could be potentially what's going on with your patient. And then finally, if you do find a distended bladder, and typically we use 150 mLs considered distended for post-void, you might consider inserting a catheter to decompress it. You want to consider also, why are they having a distended bladder and they are not able to urinate? Is it medication related? Is their prostate enlarged? What is causing this? So those people might need additional workup, including labs, to make sure that they are not in AKI. And by the way, if you do find distended bladder, I typically still look at the kidneys to see whether there is hydronephrosis present, as well as that changes my management for the patient. If I see the bladder distension that's causing back up into the kidneys, I'm more likely to check labs and decompress that bladder. So this is an example of the pathway that we use, clinical pathway, to help manage patients in the outpatient setting who are presenting with renal colic or bladder, the inability to urinate. So now let's kind of look at the imaging of what hydronephrosis looks like. This is a schematic. So this is what a mild hydronephrosis, what you should be expecting. The pelvis will be somewhat dilated, and maybe it will start showing some dilation in the calyces, but moderate hydronephrosis is the one where you'll see that dilation of the calyces. You'll often see the radiologist read hydronephrosis as mild to moderate. It's definitely a spectrum, right? So there is that mild to moderate to severe category as well. And this, so this is moderate, and the last one over here is the severe hydronephrosis. And notice, not only is there marked dilation of the collecting system with extension into the calyces, but also the cortex of the kidney is thin, right? So that tells us that there is actual damage to the renal parenchyma, and that requires immediate attention. So the difference between moderate and severe is really that cortical thinning that's not present in moderate, but present in severe hydronephrosis. These are some of the examples for you to look at all at once for just comparison. So normal, we discussed, you have a hyperechoic center here. So collecting system is collapsed. And mild, you start seeing dilatation of that pelvis and maybe some extension into the calyces, or sometimes you'll see just like a sliver going across the kidney. While in the moderate, there is definite extension into the calyces, and the calyces are full. And with the severe hydronephrosis, there's so much distension that now there's thinning of that cortex. And this is an example of a normal kidney. Once again, I can slow it down for you so you can visualize it right here. So we've got that hyperechoic center, and notice the renal capsule, it's hyperechoic, and the rest of the parenchyma is relatively hypoechoic to the kidney. This is an example of mild hydronephrosis. So notice that in this case, we are using color Doppler to distinguish vessels from ureter and pelvis. So this is a dilated pelvis here in the middle that's anechoic, that does not have color uptake. So telling you there's no fluid flowing through there. However, there is color uptake in the vessels of the kidney. So whenever you're looking for hydronephrosis, especially if you're finding mild hydronephrosis, it is important to use the color Doppler to make sure you're not actually looking at a vessel. This is more of the examples on a transverse view. So on a transverse view, instead of having hyperechoic center, you will have that anechoic center in the middle. And I actually think that transverse view, sometimes it's easier on a transverse view, sometimes it's easier to identify hydronephrosis than on the long view of the kidney. And this is an example, once again, of using the color Doppler that shows flow in the vessels, but not in the actual pelvis that's distended. Take a look at this image over here. I'll let you think a little bit about it. There's two findings here. Obviously, something to do with hydronephrosis. So think about, is this mild, moderate, or severe? And there is some also hyperechoic punctate lesions that you can see throughout the kidney. So this is actually moderate hydronephrosis with some stones that have not moved, but are probably going to cause some trouble for this patient later in life, right? So you see there's stones all over here. And also notice on this view, we are seeing a tiny bit of fluid in the renal capsule. So there's an anechoic sliver right here. So this actually signifies that most likely one of the calyces has ruptured, and that created the fluid around the kidney. This is another example of moderate hydronephrosis. There's quite a bit of, I would say this is almost moderate to severe. There's quite a bit of distension. There's extension into the calyces. However, the cortex doesn't look thinned. And you probably guessed it, this is the severe hydronephrosis. There's a lot of distension. There's pelvis is distended, it's connecting, but the calyces distending those. And now there's so much pressure that the cortex is getting thinned. One of the very frequent things you'll find on ultrasound when you're looking for hydronephrosis are renal cysts. So I wanted to give you a few examples of those, and sometimes they can be medullary cysts, kind of more like this in here, and sometimes they are more cortical cysts. So there are two cysts in this patient, right? This one is getting measured here, but notice that the actual collecting system is not dilated in this case, right? So this patient does not have hydronephrosis. You are seeing quite a bit of anechoic structures, but those are not hydronephrosis because they are not connecting into the pelvis. So it's important if you do see patients with a lot of anechoic materials that look cystic, but you're not sure whether it's hydronephrosis or not, is to make sure you're following the fanning slowly to see how this anechoic area connects. Does it connect to the pelvis? Another important thing to do is look for any internal echoes or septations. That signifies a complex cyst that should get follow-up, versus if you're seeing anechoic material only and it's likely a simple cyst, those patients don't need follow-up. And then another thing I typically do is I do put the color Doppler on the cyst to make sure that there's not an aneurysm or some kind of vascular pathology that's creating this anechoic area. So if you see a simple cyst, no follow-up is needed. If you see a complex cyst, follow-up should be performed. Key is to distinguish it from hydronephrosis, and also make sure it's not vascular. This is an example of urinary retention over here. So the bladder is just very, very large. And if you were to measure it, it's probably going to be around 700 to 800 cc's. But although it's good to measure for the chart purposes, just visually it looks very distended. So typically we use post-void residual as 150 to call this distended. I wanted to share some other renal and bladder findings that I thought could be interesting and valuable for you to learn about. So this one is a color Doppler that was placed over the bladder, and we are actually looking for urethral jets. So if one side is blocked with, say, a kidney stone, then you're not going to see a urethral jet on that side, right? So in this view, we are only seeing urethral jet on patients left, not right, telling us that there's a good chance that there is a kidney stone that's passing through the ureter on the right side. This does take some patience. You might need to wait for a couple of minutes for that urethral jet to show up. So this is not typically a part of standard POCUS where you want to move fast and you have 2 to 5 minutes to perform it. This takes a bit longer. This is a fun image here. Do you guys see this circular structure in the middle of an anechoic structure, right? So this is actually a bladder. At the side of it, there is a Foley balloon. So this is a way to confirm that the Foley is actually in the right place. This, on the other hand, is a Foley being in the wrong place. So the bladder is up here, and this is actually an enlarged prostate, and it's getting further enlarged by having this Foley balloon inflated within the prostate instead of the bladder. So this is something you can do at the bedside to figure out what's going on with the Foley. And I let you kind of look at this ultrasound here just to give you a lay of the land a little bit. This is, I believe this was the liver. Yes, liver here. So I want you to notice this whole structure and this. So actually what's going on here, this is a hematoma, and this is a kidney being pressed by that hematoma. So this happened spontaneously in this patient who came in with right flank pain, and we were concerned for a kidney stone, and we went to ultrasound instead of a hydronephrosis. We found this. This is actually quite a rare occurrence, but this patient had a pseudoaneurysm of his renal artery that leaked and caused this hematoma. So he ended up going to ICU for monitoring, and he actually ended up having coils put into his pseudoaneurysm to stop the bleeding as well. So once in a while, you will find things that are very concerning, and if you can recognize them at the bedside, that would really be important for patient outcome and further your pathway for your next for your clinical management. So what is the impact of renal and bladder ultrasound? Well, number one, you are improving your diagnostic accuracy. Even if everything is screaming at you, hey, this patient has renal colic, I'm going to send him home. He's had multiple of those. Well, guess what? If you put your probe and you find that mild hydronephrosis, that just confirms your decision making, right? And you can safely send that patient to the ER, to home. Versus if you do find that moderate hydronephrosis is severe, well, moderate hydronephrosis, the patient is more likely to have a stone that's large and might need an intervention. So you would have a different type of follow-up for that patient, or maybe you would get a CAT scan on that patient to decide to see what size stone they have. Versus someone with severe hydronephrosis, you would send them to the ER. So it does make a big difference. In terms of the impact, you really get to insert a urinary catheter when it's indicated. It's not longer a guesswork here. You get to avoid the CAT scans and radiation that comes with this, and also you get to save time and costs for the patient, which is really huge for patient experience. So to wrap it up, last question, is this hydronephrosis? And this is a really trick one because that does look like there's some anechoic area in the middle that might be extending into the calyces. But because you learned about the use of color Doppler, whenever you see hydronephrosis, to rule out vasculature, we did put a color Doppler on this. And this is actually not hydronephrosis. This is just normal vasculature of the kidney. So to summarize, couple of things. When you're doing renal ultrasound, especially on the left, you might need to rotate the probe to be in line with the ribs. So typically it's clockwise rotation. So you're in an oblique orientation lined up with the ribs on the left. You can also have the patient take a deep breath to bring the kidney down towards your probe, and it comes below the rib cage so you can image it a bit more easily. Make sure that you know how to distinguish renal cysts versus hydronephrosis. Always compare to the unaffected side. So someone who has, for example, prominent pyramids that also look a bit hypoechoic in ultrasound, see whether they have the same thing on the other side, because if they do, it's less likely for this to be a pathology. And do provide follow-up for complex renal cysts. I wanted to also tell you a few more things before we take the Q&A, a few more webinars that we have coming up. So one is July, we're taking a break, but in August, I am hosting a webinar. Holosono is hosting a webinar on the business case for POCUS. So really looking into the ROI for point of care ultrasound. This is a QR code if you'd like to register. We'll also follow up in the email and share it in chat. We have another webinar, more clinically focused, and this one is on gallbladder ultrasound. This is hosted by SMA on August 25th. So this is the QR code for that, and we'll share that in the chat and the email as well. And finally, I did want to invite you to use some of the resources we have at Holosono on our website. We have quite a few free resources around ROI. So we actually have CPT codes available for download with current CMS rates for physician fees. There are ROI calculators, there's CBT clinical pathways, and a few other resources that might be helpful.